welcome to today's webinar. My name is Trevor. I'm the Communications Manager for the Canadian Cancer Survivor Network. Thank you everyone for attending today's webinar, the latest in the fall leg of our 2025 webinar season. If you're new to our webinar, a little background on our group. CCSN works to connect patients, survivors, and other stakeholder groups with decision makers and the wider community to engage in discussion and to act on evidence-based best practices to alleviate the medical, emotional, financial, and social costs of cancer. To learn more, visit survivornet.ca. This webinar is being recorded and will be available on YouTube, and a link will be provided by the email you registered with, along with a link to the slides provided with this presentation. We'll add a quick Q&A session at the end, but if you would like, put in your questions in the chat at the end. It should be at the bottom right of your screen on the GoToWebinar screen. A big thank you to Bayer for facilitating this webinar and their continued support of the webinar series. This webinar was also made possible by grants from AbbVie, Amgen, AstraZeneca, Eisai, Bristol Myers Squibb, Janssen, and Merck. It's because of their continued support that we can host the CCSN webinar series, and thank them for their commitment to our educational endeavors. Today we are talking about a focus group we conducted earlier this year, and we will be hearing from those who worked on the project as well as some patient advocates to go over the results of CCSN's prostate cancer focus group. I would like to introduce the first doctor first. Andrew G. Matthew, PhD, C.Psych, is a health and clinical psychologist as well as a clinical investigator in the Department of Surgery, Division of Urology, and associate professor in both the Departments of Surgery and Psychiatry at the University of Toronto. He serves as the Lead Psychologist, Director of the Sexual Health Program, Director of Psychology Training, and Head of the GU Survivorship Program at Princess Margaret Cancer Centre in Toronto, Canada. His clinical care and research are centered on urologic cancers, focusing on the prevention, sexual health, survivorship, and improving patient quality of life. And so without further ado, please take it away, Dr. Matthew.
All right, thank you very much for the very kind introduction. And I just want to say it's a pleasure to be involved in this webinar, and it's always a wonderful opportunity to talk to patients directly. So I appreciate that. The title of my talk is the Prostate Cancer Patient Focus Group, exploring the experiences of patients with metastatic hormone-sensitive prostate cancer. The focus really is, I want to go through the kind of quality of life, less directed towards, the effectiveness in terms of cancer control, but more, how does this affect patients in terms of their quality of life? The reason being is that it becomes important that this is more seen as almost like a transition from an acute care of cancer to a chronic care of cancer. And so how do we help patients who are continuously being treated to live the best quality life they can? So we'll just review that. And next slide. I have just these disclosures here. I am a psychologist, so don't worry, I don't get that much money, but it's not bad. There you go. Next slide. Yeah, thanks. So it is true that androgen deprivation therapies and RPs do improve survival in advanced prostate cancer setting, whether it be castrate sensitive or castrate resistant. It's also well established that these treatments do significantly have significant adverse effects, and but it's important to know that since RPs are relatively new in the last number of years, we're now able to take a look at some of the quality of life impacts above and beyond traditional ADTs, and they do not seem to appear to appreciably increase that side effect profile. And so that's good to know. This the health-related quality of life effects directly of RPs would probably be already developed by the original ADT, so it kind of washes out the effects likely. Next. So it's also very important to recognize that, and if you're on an androgen deprivation therapy and you're in hopefully in a community support group and you see other patients on androgen deprivation therapy, you'll probably personally have experienced the fact that patients do vary widely in their expression of these side effect profiles. And this isn't particularly well understood, but if we go through the literature, we really do find that the disease stage may play a role, the extent of metastasis may play a role, the length of time that you're actually on ADT can play a role, intensity of any pre-treatment for For instance, radical prostatectomy, radiation treatments can play a role. And also just pre-treatment physical health, how you are in terms of your own physical health and fitness when you come into being treated, and as well the age of the patient. So with respect to this, my recommendation is consider yourself an N of one. Don't get too caught up on the aggregate, statements that are made. May be very different for you. Next. So Chris is speaking, Dr. Wallace is speaking next, but I like to always steal his slide, so it's great. So I get to present it before he does, and it's a wonderful slide, but it does show you the myriad of potential side effects. But I don't want you to be overwhelmed by this, because some are more common than others, and some have more or less effect on quality of life. And next. And the problem being is that we do know that generally people don't get off scot-free on androgen deprivation treatment. So this will affect your quality of life, but it may also affect adherence, and that becomes very important, is that it's a very effective treatment. So trying to stay on it becomes very important, and how we can really help you in the cancer care system is to provide care for those side effect profiles. And that's what I hope to discuss today. Next. So to make it simple, the idea is that I kind of broke it down into quality of life domains. So we look at the physical domains, the cognitive domains, the masculinity domains, sexual functioning domains, and psychological domains. And I'll go relatively quickly. My talk is no more than 20 minutes. And the reason being is that I think just having this quick overview, if you're on androgen deprivation therapy or a partner of those you'll recognize some of these things. And then we have, luckily enough, we'll be able to discuss this more as a group. And I think that will be very helpful as well. Next. So from a physical perspective, next. Fatigue. I put this up first. About 40% of men will experience, those that are on androgen deprivation therapy will experience fatigue. And it is one of the most distressing side effects. It's the one that I see that can really affect one's quality of life if basically you're aware of the fatigue but are doing nothing about it. And there are things to do, not the least of which is appropriate sleep cycles and the like, but exercise is hugely important. And what you'll note as I go through each of these domains, exercise is going to be on almost all of my slides. And I'm a psychologist, so I should be talking to you about the psychological distress and how that can affect you and the like. And it's very true. But when I'm talking to my patients, I will always say the single most important thing that you do is to exercise when you're on androgen deprivation therapy for a number of its benefits, making sure that you're checking with your oncologist or physician to develop an exercise program that is safe. So again, it's one of the most important side effects in androgen deprivation therapy. Next. Hot flashes are also quite prominent, and in the literature, we're never quite sure whether we describe them as hot flushes or hot flashes. So I like to use both and bounce back just to confuse everything. But the idea is about 80% of men on androgen deprivation will experience hot flashes. And usually we don't think much about hot flashes when we learn about androgen deprivation therapy and we learn about the potential side effect profile. But once you've gone through hot flashes, it can be quite distressing and quite challenging. And about 1/3 of men will find this to be the most bothersome side effect. And it also has a practical challenge, and that is that it can often interfere with sleep. And we'll talk about that in a moment. In terms of intervention, probably the most effective medication-based approach to hot flashes are hormonal agents. The only problem is that there is some evidence in certain situations that they can interfere with androgen deprivation therapy because, of course, they're hormonal approaches or agents. Plus, they have their own side effects as they are. If we go to non-hormonal medications like SSRIs or SNRIs, these are known as anti-anxiety and depression agents, but they also seem to be, in some cases, helpful in hot flashes, but certainly not fully effective. And then we have neuroleptic agents. And so taken together, I think if you're experiencing hot flashes, at least the very first step is probably the non-medication route: acupuncture, meditation, relaxation, deep breathing. See if one of these approaches can be helpful, at least initially, as you adapt and adjust to hot flashes. Most people will adapt and adjust to those over time as well. Next. This is the trifecta. So we just talked about androgen deprivation therapy has a direct effect creating fatigue in many cases. Then we talk about hot flashes that interfere with sleep, and then we have a sleep disturbance, and we're not getting as much sleep. And what happens is, if you take a look at all three of these things, you get into an exhaustion cycle. And the problem with that is that, as you know, when you're really tired or exhausted, your buffer are down, your ability to be resilient drops as well. So we really want to focus on all three of these in order to make sure that we don't fall into this exhaustion cycle. The more well rested we are, I mean, it's just incredible in the literature, the relationship between sleep problems and depression and low mood and lack of social interaction. And so making sure that we do our best to focus on each of these in order to make sure we don't fall into that exhaustion cycle becomes important. Intervention, again, probably the most important thing you do is exercise. So I put that there. There's also, some of you may have heard of cognitive behavior therapy, which is a therapy used for mental health, but they've also kind of remodeled it to work with insomnia, which is called CBTI, cognitive behavior therapy for insomnia, which is also quite effective. So you might think about that as well. Next. Weight gain and muscle loss is common on androgen deprivation therapy. Fat mass can increase by as much as 10% in men. And there's also this experience of reduced muscle strength. We can use exercise again under these circumstances, but have realistic expectations. The likelihood of building a six-pack while on androgen deprivation therapy is probably not there. But can we maintain our current muscle or reduce the expected loss related to ADT? Yes, that is likely available to you as well. So that also helps just the exercise from a mental health perspective. We also have loss of bone density. There are interventions that are available for that. We know that many patients will lose some bone density. The best thing to do is get a baseline bone density. You start on androgen deprivation therapy and then monitor it over time. And if we get some losses, then we can integrate some treatments. And again, not the least of which is exercise. But the other thing is just a reminder that we have weight gain, muscle loss, and loss of bone density. This is where a fall risk can become problematic. And so just being aware of that. The maintaining your weight and the muscle will help with the fall risk. And that's a good thing, given we want to make sure that you're not prone to fracture due to bone loss. Next, cognitive section. So this is the one that's I find is scariest for patients. It's nothing like saying, hey, you're on a treatment and it may affect your cognitive function. That's kind of like saying, hey, if you get this answer wrong, you might get a shock. I don't know. Does the shock mean like a little pinprick, or does it mean like I'm going to get zapped, right? It's cognitive function is just too broad a kind of quality of our characteristic that when anybody says that could be threatened, we can become hypersensitive to it. And so the idea is that we want to have these kind of realistic and more balanced ideas of how this might affect us. We do know that neural centers do have androgen receptors, and for instance, the hippocampus and the amygdala. So there's an action or by which this might be able to, which androgen deprivation therapy might affect cognition. But there's really mixed results in the literature. a large prospective study set found no effect. Another one found 67 to 69% experience impairment in at least one cognitive domain. A systematic review said the overall quality of evidence was relatively low. And I think probably the highest area that we see this is in two. One is word finding. And, you know, we have word finding problems as we age anyway. But the other is the visual spatial. So the idea of knowing that there's a desk behind me, and then I have a visual spatial memory of that, and then that may be affected, so I might forget that. So a good reason for not leaving things on your stairs, for instance, could be helpful. But again, people will respond differently. I think the cognitive function concerns are probably more related to the overall fatigue-based thing rather than a direct action of the medication. And I always use an example that there was a university professor that I treated. He was 12 years on androgen deprivation therapy. He was a mathematician. I really enjoyed his company. And when he came off androgen deprivation therapy about a year later, he said, you know, I can see a little refinement of my executive function, but not a lot. And I can tell you that in the 12 years that he was on androgen deprivation therapy, he published more papers than I did. So not bad. All right, next. In terms of sexual functioning, next, you can see that we have something called the sexual cycle. And so, and androgen deprivation therapy does seem to have an effect kind of across the board. Probably the single greatest is reduced desire. Then it can have effect on erectile dysfunction. It can cause difficulty reaching orgasm, or delayed orgasm, or anorgasmia, or no orgasm at all. Reductions in overall relationship intimacy, and also body image concerns. So let's go through those. Next. Just reduced desire, but 94% of patients will say they lose their sexual desire. And I really think that testosterone is is the single greatest influence of a male's sexual desire. And the interventions are challenging under these circumstances, where obviously we would, if there was low testosterone in a male who didn't have cancer and wasn't on androgen deprivation therapy, we could increase that testosterone through testosterone replacement. But that's not an option, obviously, because the very treatment is to remove testosterone from your system. There are sexual health clinics in some oncology centers, and they'll have more knowledge of this than the community centers. They can be helpful. But also just remembering that as if your partner having open communication about this can be helpful, so that you're both going through the journey together rather than being on separate pages. Next. 73% will suffer erectile dysfunction. This seems to be a direct effect from androgen deprivation therapy. And a little caveat here is PDE5 inhibitors that you would know is like Viagra or Cialis aren't as effective in the context of androgen deprivation therapy, so just be aware of that. But there are lots of other interventions that we can introduce to try to restore erection. Next. Intimacy concerns. This is a hard one. 83 to 93% of couples will cessate sexual activity altogether. That means stop engaging in sexual activity. And this can reduce overall relationship intimacy. And here's where we really want to, the way it's treated in the literature now is like a biopsychosocial approach. So we look at physical, emotional, cognitive, and social aspects when treating it, rather than just treating the erectile dysfunction. But the other aspect is intimacy counseling or sex therapy can be helpful. There is not a lot of within our hospital systems care that's specific to this. So you may have to go to the community and just make sure that you find somebody that has some background in this to help. Next. Body image. Many men will describe that they have body image concerns, and this is because there can be changes in body shape and size. You can actually lose size in genitalia. You can get some fatty tissue in the chest area. It also creates some abdominal, so right around the waist, you can get some weight as well. And so we can work with this in terms of in cancer care and cancer survivorship. We do have a fair amount of experience working in body image, so make sure you seek that in your centers. But where this concerns me the most is that if it interferes with the gentleman going to a gym, and I think that's hugely important, that that going, if your exercise routine involves going to a gym is much more important than not. And so see if you can find some kind of interventions like compression clothing can help instead of showering at the gym, showering at home. And then recognize we're unbelievably adaptive creatures. So even the body image concerns now, over time, it's really lessens. But again, exercise is helpful in this realm. Next, masculinity. Next, it's strongly associated with reduced self-appraisal and masculinity. About 15% of men report feeling less masculine, and this increases over 36 months. So the idea is that we're, again, very adaptive, and just being psychologically more flexible, having a broader sense of masculinity about being a father or a partner or an uncle or a colleague can be a very important role in one's life. And so we just want to be aware of this kind of shifting and not putting too much on our traditional masculine belief systems. Exercise, again, can be helpful because it connects with your body again. Next. And then emotional. I think, one that's important is just this exaggerated changes in emotion. This can be fatigue related, more irritable and more angry. But one that's less spoken about, which is really interesting, is this difficulty maintaining stoic emotional expression. Now, only psychologists could come up with such a ridiculously long term, but the idea being is what we're talking about is you have a tendency to be more tearful or spontaneously tearful or show emotion. And the reason for that is testosterone is kind of our fight hormone. And so, if we're looking at saber-toothed tigers, we don't want to break out into tears. So testosterone helps us maintain that stoic expression. When we take the testosterone out, we're more prone to tearing up, and some men find that shameful or embarrassing. And so just getting used to that. And so an intervention is just being, embrace the sensitivity rather than see it as a weakness or a vulnerability, and then let others know that, sometimes you're more tearful than they might have known you, and not to be concerned or upset about it. Next. And then we have depression, another thing of mixed results. But we look at the general population, about 11%. Post-radical prostatectomy drops down to 9%. That may be because they're feeling wonderful that they believe they've been cured of their disease. But prostate cancer patients on IDT do have an increased significant depressive symptoms by about 39%. And systematic reviews show that these depressive symptoms may even drop down, potentially because the addition of an RP gets better pain control and increased activity. The other thing that's really important here is that it may not actually be that you're suffering depression, but ADT side effects. If you take a look at this collection, in much the same way that if I was to diagnose depression in the community, the side effect profile of ADT almost mimics the same symptom profile, and hence some men will say that they feel, or they think they may be depressed, and that's because they're just trying to get to this equilibrium of this kind of mimicking side effect profile of androgen deprivation therapy. Next. Interventions, we have antidepressant medications. Again, interestingly enough, the normal antidepressants are not, the common ones are not as effective in the context of androgen deprivation therapy, but psychosocial interventions are, in cognitive behavior therapy, is used for this form of depression. And again, exercising also helps with mood, and it helps distract you from being in the critical low cognition, low mood, by just focusing on the fact that being on an exercise cycle makes your muscles hurt, and you're focused on that. So it can be helpful. Next. And then we have patient support groups, and I think many of you are aware of this, but they're remarkably helpful to feel like you're part of a community. So keep that in mind as you go through this. Next. And then we have online educational resources that you can find. This is actually one called Life on ADT that's developed by Canadians, specialists across the country that can be helpful as well. And next. And there's psychosocial support sometimes within the centers, but also you can take a look at health psychologists. There are clinical psychologists, health psychologists, and sometimes both, but they can be helpful too. Next. And then similarly, just in terms of exercise and rehab resources, if your hospital doesn't have one, in Canada, we have Wellspring, usually across Canada, as well as Guilds Club, all of which could be very helpful and have their own exercise programming that is well vetted. Next. And then social support. Boards of family and friends, remembering that when you need some help, it's not pity, it's how we actually cope with almost all things. It's much better when we work with others. So including others in your experience is a form of intimacy, a form of bringing them into your experience and allowing them to explain their own experience. So don't underestimate social support. It's the second thing I ask about in an intake interview in terms of psychological well-being after being diagnosed with cancer. Next. All righty. Thank you very much. And I will let our host introduce Christopher. I know that we rapidly went through that, but I think that sets the stage for a very enjoyable talk after Chris's talk.
Absolutely. Thank you very much, Dr. Matthew, for that presentation. That was wonderful. And so now I'd like to open the floor to Dr. Christopher Wallace, MD, PhD. He's a urologic oncologist at the University of Toronto, Mount Sinai Hospital, and University Health Network. He has an active clinical practice focused on prostate, kidney, and bladder cancer, as well as an extensive research portfolio, which to date encompasses more than 250 publications in peer-reviewed journals, including the New England Journal of Medicine, the Journal of American Medical Association, the Lancet, the BMJ, JAMA Oncology, and many others. So without further ado, I'd like to turn it over to Dr. Wallace, please.
Thanks so much. I think hopefully this will complement Dr. Matthew's talk nicely. It's always hard to follow him when he's speaking. So we'll try and, add maybe a little bit of more the cancer control flavor, which is obviously the thing we try and balance here, which is the trade-offs and the tension between cancer control and toxicity, because fundamentally what the goal is here is to maximize both quality and quantity of life, and we need to be thoughtful as we balance the two and doing things that may improve quantity of life at the harm of quality are obviously difficult decisions we need to navigate. So I'll get you to advance the slide. And the next one I think is going to be my disclosures, which essentially says that I've worked with almost every company that does work in prostate cancer, because all of us are engaged with the same overall goal, which is to advance care for patients with prostate cancer. Next slide. So this I think is important to think about, because we hear a lot of mixed messages around prostate cancer. At least I do, and I think my patients do as well, because you hear a lot of these media sort of messages around prostate cancer being an indolent disease or not an aggressive disease. And then sometimes I'll have patients come in and they're confused when I tell them that they have an aggressive form of prostate cancer, because they'd heard from either their friends, their colleagues, family members, or just lay media that prostate cancer isn't an aggressive cancer. And so it's important to think about the different flavors that prostate cancer can come in. Many men are diagnosed with these low-grade, clinically localized, just in the prostate kind of forms of prostate cancer, which for the most part are nuisances and not really life-threatening things. But then there's this other sort of wide spectrum of prostate cancer, some of which can be very aggressive. In particular, you're seeing on this slide something called synchronous metastatic disease, which is to say the men who show up when the cancer is already spread outside the prostate before it's even diagnosed. And these are the men where the risk from the cancer is much higher. And so as we weigh that balance between efficacy of treatment and the toxicity of treatment, the balance or the scales may be shifted a little differently. Move on to the next slide. And again, here, it really is important to emphasize that for most men who are found to have prostate cancer that's spread, this is going to be the life-limiting thing. And so we want to focus our efforts on managing and controlling the prostate cancer, because we know that most likely prostate cancer is going to be what someone who has metastatic prostate cancer dies of. Now, that doesn't say we ignore other things. Cardiovascular health remains really, really important. And as Dr. Matthews pointed out, a lot of the treatments we have harm cardiovascular health. And so we have to work hard to undo those, both pharmacologically, but more importantly, as he's pointed out, with lifestyle approaches, including exercise. And so this is, a really important balance of, management of the prostate cancer and also mitigation of the harms of those treatments. Next slide. So what's important to understand is that even within this context of prostate cancer that's spread, there's a huge variation. And so there's, a lot of work being done to look at biomarkers and very personalized things. But even just an easy breakdown here, essentially asking, did the cancer spread at the time that it was diagnosed, or were you diagnosed with localized disease and it spread later? That's de novo, which is metastatic at the time that it was diagnosed, versus metachronous spread later, and how much disease there is on the CT and bone scans tells us a lot about prognosis. And so this is based on old treatments. This is outdated therapy. This is androgen deprivation alone. But even then, we see nearly 2 or 3-fold differences in the expected life expectancy of men with advanced prostate cancer. And so there is so much variation between patients. I think it's really key to understand that any one-size-fits-all message you may receive is not inherently going to apply to your situation. That's where the individual discussions with your individual physicians are going to be key to really understanding what can be expected and the trade-offs in any individual patient's decision-making process. Next slide. So with that said, the last 10 or 15 years have been really sort of interesting and transformative time for advanced prostate cancer. Up until 2004, we didn't have any drugs in metastatic prostate cancer that had any life-prolonging benefit at all. And then in MCRPC, the TAX-327 trial, which was run by Ian Tannick at the time out of Princess Margaret, showed that adding chemotherapy in hormone refractory or castration-resistant prostate cancer improved survival. And since that time, we've added nearly 10 new drugs into the pathways of treatment, and these have moved earlier and earlier and earlier. And in doing so, we've dramatically lengthened the amount of time that men are expected to live after a diagnosis of advanced prostate cancer, but also protected the quality of life during that time. And so all of these are built on this idea that we start with ADT and we add something to it. And so as Dr. Matthews has really well pointed out, ADT is the backbone of all of what we're doing here, and we need to manage its toxicity along the way, but build on it. Next slide. And so this just highlights that in castrate-sensitive disease or hormone-sensitive disease, hormone-naive disease is a different terminology, we've seen dramatic changes in the last 10 years in terms of treatment options available to patients. And that's been really a revolution in terms of what we can expect for outcomes, and has allowed us to really prolong survival and protect quality of life. And so you'll see here this timeline that, every couple of years we've seen another advance. And I think that's a key message that men and their families managing advanced prostate cancer should probably take some solace in, is that, I just got back from Berlin for the European Society of Medical Oncology meeting, and we had, 3 new treatment approaches in MCSPC discussed there. And so we continue to add to this repertoire. We continue to add new drugs, new approaches. In doing so, we're continuing to lengthen duration of survival and also protect quality of life during that time. And so, it's a really, I think, optimistic time to think that as we go forward, we get more and more great treatment options at our disposal. Next slide. Now, I've alluded to this already, but once you have many options, it actually sometimes makes life a little bit harder. I don't know how all of you approach, you know, daily life decisions, but sometimes if you go to the grocery store and you're looking for barbecue sauce, if there's one option, you don't have to think at all. You just grab the one off the shelf and head to the checkout. And if there's 17 options on the shelf, sometimes it's a little bit difficult. You maybe overanalyze and you're weighing the pros and cons and you're trying to decide, you know, where is it produced, what's the flavor profile, what's the cost. You're trying to weigh all these decisions. So it's great to have all these options that I just highlighted that have emerged. But if anything, it sometimes makes our discussions and our decision making even harder because we have so many choices to consider that there's almost this, you know, mental overwhelming burden that comes with trying to sort through all the potential options and all the information that goes with it. Fundamentally, as we do this, these are the things that I think about as we have these discussions in clinic. We want to think about the survival benefit. So we add more therapy. We do that because we expect it to help people live longer. But there's a trade-off in terms of toxicity and the side effects of medications, and maybe that's having quality of life implications. There's questions around life expectancy. You know, if we forgot about prostate cancer, how long are you expected to live? And in that regard, you know, we maybe approach these questions differently for someone who's 50 or 60 than we do for someone who's in their 80s or 90s. It's not that we wouldn't offer aggressive therapy to older men, but we have to weigh the pros and cons a little differently. And then patient priorities always come into play. This is never more clear than in the localized prostate cancer space, where we think about things like surveillance and surgery and radiotherapy and weighing the pros and cons of each of these. But I think at every step along the way, it's important for patients and physicians to remember that different patients will come to different conclusions, even in the same situation. And that's totally reasonable and expected. And every patient is going to view the information presented to them in a slightly different way through their own lens. And that is appropriate and what we should be hoping for, to be honest. Next slide. So as we think about, you know, how to make these choices, we think about the comorbidity or the health burden that the patients start with. We think about the efficacy of the treatments and the burden that comes with those treatments. We have to weigh these off to decide, you know, to what degree can we expect to help, and in what ways are we maybe going to hurt along the way, and we can make, you know, the trade-off between those two. Next slide. So life expectancy, I think, is really important. In general, in prostate cancer, you'll hear that we generally don't go looking for prostate cancer, i.e. screening, for men who aren't expected to live at least 10 years. And that's because of the speed at which prostate cancer progresses. And you saw before that even in its most aggressive forms, most men with MCSPC, with even old, outdated treatments, are expected to live many years. That differs from some other advanced cancers, things like pancreatic and others, which may progress much more quickly. And so, you know, we need to expect that there's a long duration of life left to live before it's really worthwhile to go through all the burden associated with prostate cancer diagnosis and treatment. And so this is important in framing how we weigh pros and cons. Next slide. Now, when we think about adding treatments, one of the things we want to consider is what can we expect? What's reasonable? And we start with the backbone of ADT because that's what we've been doing, to be honest, for about 35 years now. The work that led to this was done in the 40s, but it took a while to get through to the drugs we use today, which arrived in the early 90s. And we've known, as I highlighted on that slide before, for about the last 10 or 15 years, that adding medications on top of ADT is going to improve survival. So in general, it's about a 30 to 40% improvement, which translates for most men to at least 2 more years of life. We're going to delay disease progression, and by doing that, we're going to help protect or improve quality of life along the way. And that's really the two-pronged goal here, is to prolong life and protect quality of life. Now, in the past, we used to use chemotherapy a bit more, I would say, than we do today. But it certainly remains an important part of our arsenal. Many men, I think, are a little bit reticent or hesitant around the idea of chemotherapy, but there's certainly situations where it remains a very useful part of our treatment plan. But for the majority of men with advanced prostate cancer were starting with ADT, usually injections, although now there's an oral option, and then some pills. These ARPI medications tend to come as pills, taken once or twice a day, depending on the medication chosen. Next slide. And Dr. Matthew already showed you this slide, but there's a really good synopsis that comes out of the Canadian Urological Association, which really helps us frame all the potential ways in which hormone therapies can negatively affect men. And it's important to think about these because we can mitigate these. Many of these are addressable, and we need to be aware and conscientious about how we manage them, knowing that the ADT itself is usually beneficial, but just as it comes with some costs, and we need to work to mitigate those costs. Next slide. So beyond those ADT side effects, each of these ARPI pills that we add comes with their own side effects. And again, for most clinicians, these are pretty routine medications to prescribe, and we can find ways to manage these side effects so that they have as little impact on your quality of life as possible. But certainly there are drug-specific choices that mean that for each individual man, there's sometimes a more preferable or less preferable choice. Next slide. Now, what's clear is that if chemotherapy is to be used, and in some cases it's very, very appropriate, that there is a cost of doing business with that. And so what you'll see in this blue line is that your quality of life drops for a period while on chemotherapy, and it will rebound when the chemotherapy finishes, but there is a cost to doing business. And so I think that's an important thing to think about as men weigh the pros and cons of adding chemotherapy into their treatment regimes. Next slide. And so I think it's important to take a little step back. There's a lot of things we can measure in medicine and we put into our studies and are easy to include in conversations, but there's a lot of things that are not. And so I like to try and think a little more holistically about quality of life. And so what termed AEs here are adverse events. These are the easy things for companies and researchers to capture when they're doing studies and looking at what we would call toxicity of treatment. Most studies these days now include what's called patient-reported outcome measures, or PROMs. And those are surveys that ask patients how they're doing, about their quality of life, about their symptoms. And so both of those things inside that white box can be captured and are included in most studies. And we can, as clinicians, give you a pretty good idea about what to expect, acknowledging that there is that variation Dr. Matthew alluded to. But I just want to sort of take a moment to acknowledge that there is this also X factor associated with being a cancer patient, the burden on your family, effects with work, travel, anxiety, financial concerns, the burden of coming to clinic visits, coming to the hospital. And so there's a lot more to embarking on prostate cancer treatment than is able to be captured in the studies or the data that most doctors have available to talk to you about. And so it's, I think, very reasonable to bring these things up in terms of your decision making and your thought processes around treatment choice when you're talking with your physician. And I think at times these can fall by the wayside, but they're critically important as we make treatment decisions. Next slide. And so this is the framework of how I tend to think about decision making. There's a historical model where we would deem it paternalistic, where a clinician says, this is what you have, this is what you need to do. And so this is around the informing and directing kind of way. This is, in my view, a bit of an outdated form of practicing medicine. There was a period of time where we did what we called this informed medical decision making, which in my view is actually a bit of a pendulum swing slightly too far the other way. It absolves the clinician of nearly all responsibility and just puts the burden on the patient, and the clinician just provides information in a relatively impartial manner and leaves it entirely on the patient to try and digest that information and come to some conclusion. And I think the better process in which most of us have tried to adopt and integrate into our practices these days is this idea of shared decision making. And so this is a bit of an iterative process. As a clinician, I try to take some time to understand your priorities, present the information in a way that is relevant to the individual patient rather than just a generic presentation of data. And then in an iterative way, we can go back and forth to refine what treatment options are likely to be best for any individual man and his family coming through these decision-making processes. And so that is, I think, what we're all striving for, and I think what you can hope and expect from your clinicians as you navigate these decisions. Next slide. So I think patient-centered care is a very nice catchphrase, and a lot of places you'll hear it, but it's more than just a nice idea. It's actually really, really important. And we know that for things that patients care about, it matters. For things that clinicians care about, it matters. And so when we really provide patient-centered care, because patient satisfaction goes up, there's actually better adherence to treatment plans. And as a result, we get better outcomes. So pain control is better, psychological distress goes down, quality of life improves, and disease-specific outcomes, things like the prostate cancer metrics themselves, actually are better. And so this is, I think, not a nice to have, but an absolutely need to have component of prostate cancer care today. Next slide. And so, you know, as we navigate these decisions, this is not a one size fits all. I think we do things like looking at the amount of cancer and the risk category of the cancer. And then we think about, you know, patient comorbidities, other medications you need to take, access to medications and side effects. And as we put that all together, there is usually a best treatment choice for each patient, but not inherently one that generalizes to all patients. And so this is the sort of treatment schema or plan that I think you'll see most of your clinicians navigating. Next slide. We'll just go down here. So I'm going to hand it off now to the Harrisons.
Hello, and thank you once again, Dr. Wallace. That is fantastic, and once again, very good information. And so the last part of our presentation, we would like to hand it over to Lori and Boyd Harrison. We have their bios on the screen right in front of you, but I think that it would be good to have them talk about themselves in their own words. So take it away to Lori and Boyd.
Okay, I'll begin here on I'll speak to it from a patient point, and then I think Lori's going to speak to it from a partner's point. So before I go, just a quick rundown of me. As it says there, I retired in 2009 after 30 years of policing. I retired from the Regina Police Service, and then I went and worked for our health authority as security in the hospital for another 10 years until I was diagnosed with prostate cancer in 2019. So before I go on and tell you the rest of my version, I just want to say that I can appreciate and agree with everything that Dr. Matthew and Dr. Wallace said from a patient point. It's from what I see, it's very accurate and is very informative. So for me, I was just diagnosed just a routine blood test with PSA. Then I was sent to a urologist to do some follow-up work, and after I was diagnosed, that's kind of where we started to see some problems with the system. Not so much from the quality, but more from the accessibility, because the first urologist I saw, he just gave me what he was going to do, and there's no discussion, there's no input from myself or Lori, which I wasn't too keen on. So he in turn referred me to the Alan Blair Cancer Centre here in Regina. I met with an oncologist, and from that discussion, I was referred up to the oncology group in Saskatoon. From there on, all my treatment was done through the Saskatoon group, and the outcome at that point was really good. My quality was really good. Everything was going well. My PSA test subsequent to the surgery was well. I had some problem with erectile dysfunction and urinary incontinence, but that was dealt with through some other interventions, and that was all satisfactory. We were able to deal with that post-surgery. So about 2 years ago now, my PSA started to go up, so I began to have a reoccurrence of the prostate cancer. So I was still stayed with the Saskatoon group until it got to the point, I think it was a 0.4, I think was the number that they wanted to get to before my care was transferred down to back to the Alan Blair, to the oncology. So there again, I met with an oncologist again, and through discussion, and it was we decided that ADT would be the option for me because I have some other issues. Radiation wasn't an option, so that's why we mutually decided that the ADT is the way to go. So I started that, had my first injection. I'm on Eligard, and I had my first injection this past April. And within probably a week to 10 days, the side effects started. And it started with just the achy joints and soreness and weakness. And it's progressed to virtually everything that Dr. Matthews spoke about and Dr. Wallace in their little that circle slide they gave. For me, though, I do have some hot flashes and certain things, but the hot flashes was very minimal for me. My problem was the achy joints and the weakness and the fatigue. So right now I'm kind of in a bit of a discussion with my oncologist through his nurse as to what sort of treatment we're going to do for the side effects. So that's kind of in a work in progress, so to speak, right now, and we'll see how that goes. I have another meeting with him or with the oncologist coming up at the first part of January. So we decided to try it for a year, and then we'll see from there what sort of interventions we can do. So there again, from a patient point, the quality care that I received was great. I had absolutely no concerns about that. My first problem though was accessing it, and like we said, the patient-centered care to me is very important, because like I said, with the first urologist, it was just his way or the highway, so I chose the highway, and it worked well for me. So that's pretty much in a nutshell for me. I'll keep it short and sweet, because I think we have time for some questions and answers after if anybody has any questions. So now I'll give it over to Lori, and she can speak to it from a partner point.
Well, not only a partner, but I do have a bit of a disclosure as well. I am a retired nurse, and the majority of my clinical background is in palliative oncology, family med, surgical, and a strong dabbling in mental health as well. I worked on a mental health unit as a clinical counselor for about 14 years, yeah. And just recently, when I retired from clinical quality and professional practice, which gave me more of an access to the patient advocacy and improving standards of care. With that in note, when Boyd was first diagnosed, it hit me hard, because my overall experience with cancer was, that's it. I worked palliative, so and one of my patients was a prostate cancer patient, and that's where my mind went to. That was it. My husband was gone. But in the long and short of it, I was informed that prostate cancer is one of the better cancers to get, if you want to see it in that fashion. And Boyd was diagnosed early enough so that we could look at a number of treatments for him. When Boyd went through his experience with going from the surgeon to the Alan Blair oncologist, who's a radiation oncologist, and I want to use Saskatchewan as a baseline, because all throughout Canada we have different standards of care. But in Saskatchewan, it's a good example, because between Saskatoon and Regina, there's a definite difference of how care is provided. They call it the Davidson line here in Saskatchewan. It's not quite halfway, but Davidson North is Saskatoon and Davidson South is Regina area. In Davidson South, it's more doctor focused, as Boyd had said with our first surgical consultation. And he originally was supposed to go to Vancouver for brachytherapy, and they weren't providing brachytherapy here in Regina. So Boyd had that option, and that's what his surgeon wanted Boyd to go for. Well, in the long and short, if Boyd has ulcerative colitis, radiation therapy is not a very good, not the best way for him to go. So he wanted to go the surgical route. So that led us to, okay, who is a good surgeon for us to consider. And Boyd had done his research in Saskatoon. He said, I'd love to go to Saskatoon and to the Saskatchewan Urological Group in Saskatoon, where we met Dr. Jana. And my God, it was like a world of difference there. He sat down, he spoke with us, he gave us an informed decision-making, just like Dr. Wallace had mentioned, informed decision-making. But there was also an added bonus of patient input. And of course, myself being a nurse, you know, I didn't realize that after you had a prostatectomy that you could still have it. My husband could still have an orgasm, a dry orgasm, mind you. But I thought that was it. You know, like, you know, my mind went the opposite direction. The glass is half empty. But it was still hope. So that was a godsend for us. Also, the difference between Saskatoon and Regina was a form of patient-centered care, and that was where they had a nurse navigator at the SUA or St. Paul's in their prostate assessment center, where they helped us walk through the process. And a lot of patients, when speaking on the advocacy part, a lot of patients feel as though they're floundering. They don't know which way to go. Do we go the high road? Which way? What are my options? And again, with prostate cancer, there are many options, treatment options to go with. Which one's the best for them? In Regina, we have a prostate assessment clinic, but it's so underutilized and not utilized to the best capacity that Saskatoon uses it for. So that's neither here nor there. Again, when Boyd was sent up to Saskatoon, he saw Dr. Jana, and what we thought was fantastic was the referral went really quite quickly, because Boyd was referred up there on the Labor Day weekend in 2019. By about midweek, this is like Monday was Labor Day, Tuesday was an off day, Wednesday Boyd got a call from the Saskatoon Urological Group that, yes, we want to see you, we accept you, accept Carol, your care, and we found the best doctor for you. And this is where the group consulted each other and said, hey, we know the best fellow for you, and that was Dr. Jana. They looked at his specific patient needs. One of the specific patient needs that Dr. Jana had suggested before and after surgery was pelvic floor physiotherapy. Aha, another difference in Saskatchewan. In Saskatoon, the St. Paul's group covers male pelvic floor physiotherapy. Yeah, at the SHA. And they cover the pelvic floor physiotherapy. In Regina, they do not cover male pelvic floor physiotherapy. Same province, same healthcare. Why is the difference? Female pelvic floor physiotherapy is covered all throughout Saskatchewan, but not male. So for Boyd to have that form of care after surgery, he would have to go back up to Saskatoon. Not in the middle of winter do you go up. We're driving the roads for 2 hours. So we were lucky enough that we had extra health insurance to do that down here in Regina. So, but if someone finds that as a barrier, it's going to become more prevalent. So Boyd and I, began to lobby the Saskatchewan government for changes in regards to pelvic floor physiotherapy, and COVID hit. So we're still waiting. Yeah. And we've actually advocated for, or myself have advocated for, at least 5 different fellows and people that have come, we've encountered throughout our time. That's why we felt it was so important for us to get our message out to people. Post-surgical, Dr. Jana's group and the prostate assessment group did a fantastic job of following Boyd's PSAs. They were there lickety-split within a day or so to go over the PSA results and stuff. Also, we had gone through penile rehabilitation. Now, this is also very important after and before to inform the patient, like myself, that there's still hope for an orgasm for my partner in regards to penile rehabilitation. But part of that is to get at the penile rehabilitation, lickety split, get at her, get things going. We were then consulted. We'd gone through the whole gamut. We'd gone through the penile plump, the clamps, I can't remember the injections. The injections were rather interesting because me as a nurse, I want to help my man when he can't inject on the poor side of himself. And well, it was a little scene out of What About Mary there with the bleeder and the zipper scene. So, but neither here nor there. Again, we all learn, correct? And my husband, I was okay with the penile injections, just for the simple reason I knew it was a safeguard. We still had a happy medium here, but my husband wasn't very happy with the fact of a 45-minute planned spontaneity. No, it doesn't work very well. So he was looking at getting a penile implant. Yeehaw, yep, we've got the implant, and we were extremely happy with that on both parts, gentlemen. Then with Boyd's reoccurrence, and he had mentioned that after 2 years, or 2 years ago, pardon me, that's when his PSA started increasing. And of course, we were following it with Dr. Jana's group. You know, they're there, you know, helping us walk through it. But we got to the magical number of 0.4. And here in Saskatchewan, and I'm not certain across Canada, if that's a magical number that we kind of said, okay, now we've got to do something with these increased numbers of PSA. That Boyd's care was then transferred back down here to Regina to Dr. Amjad. And again, because Boyd has such a unique case, usually the conventional route is to diagnose where, if the cancer has spread and metastasized, to do the conventional testing, such as the bone scans, abdominal ultrasounds, and so forth, at 5 different scans. My poor husband even had a brain scan because he was having some cognitive changes, and we'll get to that in a minute. And of course, radiation was the last thing that we wanted to look at. Of course, ADT. Now, from what I understand, the PSMA PET scans was a diagnostic tool, not only diagnostic, but you can now use it for treatments. But that was an option. It was just a one-time thing. You find out where the cancer's at. And Boyd can testify, like we've attended some American Can-Am groups. ANCAM, where the American doctors are, oh my God, you know, like, you've got this PET scan. Why don't you go directly to that as opposed to all these other scans? And we said, excuse me, but standards of care in Canada are a little bit different. And then we look at provincial and, you know, and the skill levels. And, you know, there's a number of things you have to consider, but they were just like Johnny on the spot, Veterans Affairs, let's go, you know, let's get this PSMA PET scan. And of course, Boyd said, no, that's not an option for us. In regards to the radiation, and that was also a factor when with Boyd when he was first diagnosed. And we thought, no, you know, you don't go for that. You go for the one with that still gives you some, you know, quality and quantity of life, but you have to go for with that to get the best outcome as well. When Boyd started ADT in his Elgard, he had mentioned like 10 days into his injection. And of course, being that partner, you can see the changes, physical, psychological, the whole change. And it's very tough to watch. And I'm kind of getting choked up talking about this because I love this person very much. This person is my world. And it's very tough to watch him slowly fade away. I kind of like to equate it to like Monty Python and the Black Knight. And in the forest, and the Black Knight's there, and he's getting limbs hacked off here and there. And he says, that didn't hurt, that did. Very stoic, very stoic. And men are typical. We don't cry. You know, that didn't hurt, you know, and march on. And I praise him for that, but I also say, you know, it's okay, hon. you can cry, you can have that meltdown. That's what I'm there for, to give you that shoulder. And that's where that picture kind of came from, that we had gotten done. It's professionally done by a friend of ours who is a professional magazine photographer down in the States. And I've got his back. I'm there for him. When he started the ADT, I'm going to go back to that, is I noticed that he had a disease when he was younger called Perthes disease. And this is why it's so important for the healthcare team to sit back and not just listen, but actively hear what the patients are telling us. And I include myself into that, is because I'm still advocate, and I still do one-on-one supporting. With my husband's Perthes disease, he was having a hell of a time, and his gait was becoming worse and worse and worse, to the point where he had more fatigue. He's an avid gym goer. He didn't even want to go to the gym. And I'm like, something is not right here in Denmark. And what we had found was, because of the Perthes disease, I'm going to use my hand and the hip and the socket. And what had happened was his femur had come out of place, and he had subluxation of the hip. This man was walking around with a partially dislocated hip for how many months, because of the loss of muscle mass. Bone mass was okay, but loss of muscle mass and the connective tissue. Now you have to remember, with the connective tissue, it's going to loosen up. Me as a woman, I remember when I had my kids and all those muscles went all south, literally. But in him, it took what he had and made it worse. So that's why it's so very important to be that active listener. Now, also, I know Dr. Matthew had mentioned about the cognitive part, and I don't know if this is a factor or not. And my poor man has, okay. But we also noticed a change with cognitive. And again, they thought my husband had a stroke. And we had laid down for a bit of a nap in the afternoon. I crawled into bed, and Boyd got up and went to the washroom and came back, and we were just having an afternoon nap. And he started whispering to me, "Lori, it's a secret." What's a secret, honey? Explain. What's a secret? Something's not right. What do you mean? He knew he was able to identify the fact that something wasn't right cognitively, but he couldn't identify it. Okay, red lights are flashing in my brain. We come from a family of nurses. I call my son, who is a trauma room nurse. "Honey, come here. I need you now. I think your dad's having a stroke." Take him to the ER. They figured it was a TIA, or a transient stroke. But the cognitive ability, he was able to identify the fact that he couldn't, he knew, he sensed something wasn't quite right, but he didn't have the memory to know what had happened over about a half hour to 45 minutes. And of course, I'm doing all my nursing assessment tools, and I'm getting in there and thinking, oh my God, that's is it. I've lost my man again, in another form, cognitively. And I think that's one of the toughest ones, when anyone goes through like a form of dementia assessment and that, and that's where it's very important, because the doc in the ER here in Regina, and our son figured that my husband was cognitively losing it well before, but I knew he wasn't. And she looked at me and she said, "No, Lori, you are the partner. What are your observations? What do you see?" There you go. You're encompassing the family, and it's more patient-centered, and that is a team approach. We, as a healthcare professional, we can't know everything. I know even oh my God, I'm the number one person to say that, but I've worked in a number of team approaches, and I've seen them work. I've seen the nurse navigators where they sit and they actually hold the patient's hand and say, "Okay, this is okay. You've got this anxiety. Let's deal with it. Let's work through it." That's the same with if a person's going through some rehab problems. We do not go to an ICU nurse for rehab. We go to a rehab nurse. If you have a plumbing problem, you go to a plumber. If you have a mechanical problem, you go to a mechanic. And this is why it's so very important to incorporate patient and physician focused care together, a blended team. Thank you.
Thank you very much, both Lori and Boyd. That was a very, very amazing story. So thank you so much for that. We do have a brief moment for questions, but I don't know if we can get to all of them today. I would like to thank everyone here for the presentation, but also thank to Bayer, and as well as AbbVie, Amgen, AstraZeneca, Eisai, Bristol Myers Squibb, Janssen, and Merck for their continued support of the CCSN webinar series, and also to remind everyone that we can see all of our webinars on survivornet.ca/webinars or on CCSN's YouTube channel, and to catch up with the next one, to just to check your emails and to make sure that you're subscribed to our newsletter. But going into the questions, we have a couple. First off, do either doctors believe we will see the day when castration is no longer used for treatment? I just wanted to remind that both Matthew and
yeah.
both. There you go. Thank you.
Maybe I'll take a run at it first, Andrew. So, you know, one of the things we think about is really that prostate cancer is a testosterone or a hormone-driven cancer. We have lots of treatments that are trying to access this through non-hormonal pathways. So, for example, we think of, you know, we just heard allusion to PSMA PET, but the corollary to the imaging is the theranostics, which is lutetium PSMA. We're looking at, you know, you can go back and think about chemotherapy, which is not a castration pathway treatment. I think in the short term, what's more emerging is the idea of using some of these more advanced hormone blockers without the ADT component. So, for example, you'll see in a trial called Embark, which was presented recently, we use the ARPI medication enzalutamide without the ADT injections. And so there's some trade-offs here. You gain in certain regards with less toxicity, but you gain new toxicities when you do that. So, for example, you don't have the ADT injections. It tends not to have the libido effects. And so you preserve your libido, preserve a bit more sexual function compared to having the ADT. But conversely, just because of the way hormones are handled, the testosterone levels rise actually, not in a way that harms the cancer, but in a way that the body then turns testosterone into estrogen. And so men get breast development and breast tenderness. So there are ways to move away from castrating treatments in advanced prostate cancer, but they all come with their own pathways. I think realistically, over the forthcoming 5 to 10 years, most prostate cancer treatments are going to build on a hormone-related backbone. Although we are obviously always looking for different mechanisms and different pathways that can potentially, you know, reduce some of that side effect burden while getting the same good cancer outcomes.
I think I have nothing more to add. I think Chris or Dr. Wallace covered that.
Excellent. We have time for one more question. One of the biggest barriers to doing exercise was joint pain, especially in the knees. What can be done for that?
There are various centers. I think the best thing to do is if you're part of a cancer center that has a survivorship program that has an exercise program included in it, or there's, as I said, Wellspring is highly connected to the training programs of the different hospitals. And the best thing to do is to go see a physiotherapist that has experience in working in men that are placed on androgen deprivation therapy, because they are aware, and it's not uncommon, and as Boyd stated, that androgen deprivation therapy does can affect the joints and make it more challenging to exercise. And so these physiotherapists that are specific in cancer survivorship have methods that reduce the discomfort associated with the joint pain, but still allow for some levels of exercise. Not the least of which is probably the literature is moving a little bit towards resistance training versus aerobic training. We want both, but resistance training becomes important.
Well, thank you very much, everyone, for your time. For those of you who still have questions that were not answered, we will be able to talk via the email that I will send the copy of the video and the slides to. So if anyone has any questions, you can contact me through that email, and I can send them to the appropriate person. But for now, thank you very much for your time. Thank you to both the presenters and to the Harrisons for their time as well. And we will see everyone on the next one. Bye for now.